Bismillahirrahmanirrahim. Assalamualaikum everyone and good afternoon everyone to be present here. It is our great pleasure to welcome you all in our 2 days academic session, an important academic event organized by Bangladesh Specialized Hospital Academic Research Wing and our scientific partner SKF PLC. Today's CME addresses a important and relevant topics demands recently, and it is cancer screening in modern era, integrating clinical expertise with artificial intelligence. This topic reflects evolving future cancer care, where awareness, early detection, evidence-based screening, and modern technology together can help save lives and improve outcomes. It's my privilege to welcome you all in today's evening. We are truly honored by our gracious presence of our honorable dignitaries, our chairperson of our today's session, Brigadier General Professor Mohammad Safi sir, our respected special guest, Professor Dr. Mohammad Sajjad Hossain sir. We are also honored by presence of our distinguished keynote speakers, Professor Dr. Jahidul Haq sir, Professor Dr. Farhat Hussain madam, and Dr. Ferdowsa Begum madam to be here, and we are also delighted to have our panel of experts who are present here, our faculty members, our doctors, and our participants. For our today's CME, we would like to invite our chairperson of today's session to inaugurate our clinical session. Sir, Mohammad sir, please come with us.
Bismillahirrahmanirrahim. Ladies and gentlemen, Assalamu alaikum. Today is the World Health Day. So, as you know, the WHO and other organizations promote the preventive mechanisms to promote our health. The cancer screen is also to prevent the development of a very untreatable condition. We are very happy that today's CME is being organized in collaboration with the North South University with their dignified experts to highlight the changing era of preventive mechanisms in the current scenario. Modern means after 5 years also there will be modern. So modern means always to remain up to date. So we have to become up to date, how to prevent, how to screen the cancers. Artificial intelligence is now part and parcel of our life. Maybe every hour we have to consult the AI. So today we also improve our knowledge how AI can help the prevention of cancer. So I am very delighted, very happy to see all the dignitaries, all the legends of this field here, and we'll be having definitely a brainstorming sessions today in the coming few minutes. Thank you very much. It's my pleasure to inaugurate the sessions. Allah Hafiz.
So thank you, sir, for inaugurating our session. And we have two speakers who are our guests also, and I would like to inaugurate them also. They are Dr. Ishtiaq Ahmed, lead researcher, Big Max Lab NSU, and Kaji Sharia Shanti, lead developer, Big Max Lab NSU. And now for our keynote speakers, our total 5 keynote speakers with over 4 topics. Professor Dr. Jahidul Haq sir, he is consultant Department of Colorectal Surgery and chairman of PSH. His topic is colorectal cancer, awareness and screening, acts early and saves lives. Professor Dr. Farhat Hussain madam, consultant gynecological oncology BSH, and her topic is cervical cancer awareness and screening. And Dr. Ferdowsa Begum ma'am, consultant oncology, medical oncology BSH. Her topic is screening for breast cancer. And our two speakers, Ishtiaq Ahmed and Kaji Sharia Sanjeev, their topics are Oncupation Hub, bridging mammography, and clinical data for precision oncology. For now, I would like to invite on stage Professor Dr. Jahidul Haq sir to present his case, to present his topics to enlighten us. Sir, please.
Bismillahirrahmanirrahim. Good afternoon, respected chairperson, honorable guest, and my dear colleagues. At the outset, I would like to express my gratitude to the organizer for asking me to speak few words in front of you. Today I will be talking on colorectal cancer awareness and screening at early save lives. I think this is a topic of increasing relevance nowadays due to raising incidence of colorectal cancer, and at the same time there's a potentiality for preventing the disease. Can I have the second slide? Yes, this is the third most common cancer globally, and the important thing that it is most preventable cancer at present time. It is highly treatable and curable if we can diagnose the disease early and if we can treat it properly. So we should put our emphasis on how we can prevent this disease and how early we can make the diagnosis so that we can start treatment as early as possible. If you see that globally, according to the Globocan or the WHO report, in the last 2022, the globally around 2 million people being affected every year, and about half of this we lost every year, and the 5-year surveillance is around 5.7 million. If you look at Bangladesh, according to the Globocan anticipation, in colorectal cancer stands around 10th place in the cancer list of our country, and total incidence is around 6,000 patients per year, and about half of these patients, around 3,000 to 3,500 patients, we lost every year, and the prevalence is around 14,000. The most important thing that we should notice here, that there is a changing trend in the disease pattern. Most of the time we think that it is the disease of elderly people, but now it is what is happening, that if you look at this graph, you can see that from 20 to 49 years there is a increase trend of incidence affecting these younger group of people. But as we go older and older, you see from 50 to 64 and 65 plus, the trend is going down. So this is a very alarming signal that we must put our attention to diagnose this case as early as possible, but younger generations are being affected. If we don't prevent this disease, if we don't treat this disease at earliest time, probably we'll end up with most of the morbidity and mortality. Why awareness matters? This is because it is a preventable cancer. That's why we want that every people should aware of this disease. Just simply screening can reduce the risk of this malignancy around 70%. So this is a reminder, important reminder, that we must detect this disease at earliest possible time. What is the benefit of this early detection? If you look at this report, that when we detect this disease at earliest time, when you detect this earliest time, the 5-year survival is 91%. On the contrary, when you diagnose this disease late, the mortality remains at only 5-year survival rate is only 14%. So from 9 to 1, it reduced to 14% 5-year survival, just the interval of detections. But unfortunately, even in the Western world, too many patients are still missing this screening program. Even in USA, 1 in every 3 patients are not subjected themselves for this screening program. So leaving this preventable disease undetected with having increased morbidity and mortality. So this is an updated screening guidelines provided by American Cancer Society and United States Preventive Service Task Force. You see that 40, 45, 45, 75 and 76, 55. Normal standard of colonoscopy for screening program was 50 years globally. But now, because of involvement of younger age group, the standard set up now at the age of 45. So those who are at the age of 45 think that you are the best person to start screening program at this age. But those patients who carries higher risk of having this, like your positive family history, like genetic disposition like Lynch syndrome, or those who are having inflammatory bowel disease, or those who are having familial polyposis coli syndrome, these patients we should start at the age of 40, or the members who suffered from disease in the same family at least 10 years earlier in that family. So after 45 years, what happened? The average screening for colorectal cancer now stand from 45 to 75. People from between 45 to 75 should enroll themselves for this screening program. And after 75, yes, we do not go for regular screening program. It is person subject variated with the family history or those who carry the high risk. Only on those patients we will go for screening after 75 years. What are the tools available for this screening program? We have both non-invasive procedures as well as structural procedures. For non-invasive procedures, FIT, fecal immunochemical test. Very simple test. The kits are available. We ask the patient to take the kit at house. Just it has a brush. We ask just you brush the surface of the stool, then put in the kit and send it back to the laboratory within 24 hours. It cost is around 500 to 700 taka, available in some centers in Dhaka city as well. Another is the fecal occult blood test. Fecal occult blood test, with this test we detect the occult blood within the stool. Occult blood within the stool. But there are certain restriction in this that we need some dietary restrictions, particularly red meat, like you should stop at least for 3 to 5 days. You should not take any non-steroid anti-inflammatory drug for 5 to 7 days, and vitamin C for 3 to 4 days. And you need to collect the sample in 3 consecutive bowels, 3 consecutive stool motions. And apart from this, we have DNA, multi-targeted DNA test in the stool. These are the new things that are coming up. So FIT and occult blood test, fecal occult blood test, we can go annually, and for DNA test we go for every 3 years. So next, the structural devices that we have. The most important gold standard is the colonoscope. If we go for a colonoscope and then if the report is negative, then you can repeat it after 10 years. And CT colonography, those who are not interested to put themselves for these structural investigations, they can go for CT colonography, where we do not put colonoscope inside the person, but with repeated use of CT as well as plain X-ray, virtual 3-dimensional virtual pictures are taken, and then we can detect any abnormality in the colon or in the rectum. We can repeat it every 5 years, and also you can have a flexible sigmoidoscopy that can be repeated every 5 years. So what are the emerging next generation screening? The most robust clinical trial has been done with multicentric prospective study where multi-targeted stool DNA, abnormal DNA are being detected, and this abnormal DNA is considered to be a very important indication that the patient is having cancer or in a precancerous stage. In the blood, we can also go for circulating abnormal DNA test. They detect abnormal DNA. It carries about 83% sensitivity, and specificity is about 90%. And finally, we have AI-assisted colonoscope. AI-assisted colonoscope is capable to detect very early abnormal polyp in the colon. Thereby, we can detect these polyps earlier, we can remove this polyp earlier, and thereby we can prevent the development of coronary cancer. And let us see the sensitivity and specificity of, if we compare, then you can see that colonoscope is the gold standard, no doubt of it. It has 95% sensitivity and about 90% specificity. We advise for a screening program, it should be repeated every 10 years. And FATE test, these also are high adherence, because if we go for a fecal immunochemical test and if we get a positive one, then you can go for a next step. We can put the patient for structural investigations like colonoscopy. And some other like multi-targeted your stool DNA test. It is a non-invasive, but it has got about 92 to 94% sensitivity and around 87% specificity. You can repeat it every 3 years. And CT colonography, well, it requires preparation. You can repeat it every 5 years, and it is around 86 to 95% sensitivity with specificity to around 86 to 96%. So what is the conclusion? The conclusion is that if we have a fecal local blood test positive, then you have to go for a colonoscope. If you not interested to go for those first step tests like fecal local blood test or your FIT test, then you have to put yourself first to the colonoscope. So you can go for one-step screening or a two-step screening programs. So now you have to choose the right test. Those who are not interested to have colonoscope, or some people are afraid of having colonoscope, yes, they can go for fecal local blood test or FIT test. If this is negative, then you don't require to go for colonoscopy. But if it comes to positive, then you have to go for a two-step procedure system. The second step, it is the colonoscopy. So it depends on you. You can go straight forward to the colonoscope, or you can go for a fecal local blood test or a FIT test, and then you can go for a colonoscopy. So now you have to understand your risk profile. Normally, the general people, some have a common risk and some have a very higher risk. Who are those who are having higher risk? A person who is having a history of colorectal cancer, yes, he is always having a higher risk. A person with a family, a positive family history, is always carrying a higher risk. Those patients who are having inflammatory bowel disease, like or a Crohn's disease, they are subject of having higher risk. Those who are having genetic predispositions, like your Lynch syndrome, like your familial polyposis coli, all these people are having more propensity to develop colorectal cancers. So these are the people who are having higher risk categories. On the other hand, common risk means certain risks are modifiable or certain are non-modifiable. Of non-modifiable, you see that still the older people are considered that they are at higher risk. Male sex are higher risk. And some modifiable, those people are obese. Obesity more than 30%. Yes, BMI. Always a bad indications that these patients are prone to develop colorectal cancers. Those patients who are sedentary worker, have less physical activity, they are more prone to develop colorectal cancer. Those patients who smoke are more prone to develop colorectal cancer. Those who consume more alcohol, they are more prone to develop colorectal cancers. And those who are indulge themselves of taking more red meat, beef, they are more prone to develop colorectal cancers. So for assessing the family risk, you see, we follow the 3-2-1 rules. 3 means the 3 generations having colorectal cancer. It means I am more prone to develop it. 2 rules means if the same family, 2 members like father, son, or siblings, they are more prone to develop colorectal cancers. And finally, any cancers, colorectal cancers, developed below the 50 years of age, it means that the members of that family are more prone to develop colorectal cancers. So this is about family assessment. Now, again, let us compare about the high risk and the average risk. So, for screening those patients who are average risk, what I say that 45 years is our benchmark. Before a couple of years back even, we advised for colonoscope after 50 years. But now this has been reduced to 45 years because of the high incidence or prevalence of this disease in the younger patient. And the most important information is here that more the younger, aggressive is the disease. Very unfortunate. Even in the last week, we operated on a patient about 19 years, just past intermediate, young lady planning to have a study in computer science. So unfortunate. And what we got a big growth at the retrosigmoid junction with depositions in the peritoneum. But fortunate that there was no deposition in the ovaries. I was thinking that she is having Puffer's tumor, but very advanced stage. So, and also, if you go for histopathology, you will find that these patients are having more that type of histopathology report, like your mucinous adenocarcinoma or like your signatory variety. All this carries a very poor prognosis. So 45 years is age at average, but those patients who are at high risk, as I said, that those have a family history, those are generic predispositions, those are having inflammatory bowel disease, all these patients, you must start it at the age of 40, earlier. And in an average risk group, we usually make this interval about 10 years. But those who are high risk, this should be every 1 to 5 years. So frequency of screening is a big gap. Those who have average risk, you can repeat it every 10 years, but those who carry high risk, it should be with repetition would be within 1 to 5 years. For average risk, what are the best method? As I said, colonoscopy is the gold standard for screening. And apart from that, those who are not interested for colonoscope, they can go for two-step procedures like those who are fit test or FOBT test or multi-targeted DNA test. And for high-risk patients, we do not advise that you go for a FOBT or a FIT test. We advise straightforward, you go for a colonoscopy. So does all patients fit for with age and frequency for screening? No, it varies. Those patients who are having the family history, first degree relative with CRC, or advanced polyps. Advanced polyps means, you see, that there are different types of polyps that you are having. But the most polyps which have a tendency to grow into malignancy are the villous polyps. And those polyps who have a diameter more than 1 centimeter. And even those polyps which are serrated, they also have a little bit more tendency to change into the malignancy. And there is a regular, you see, that adenoma carcinoma sequence. When there is an adenoma or polyp in the colon, it takes around 10 to 15 years to transfer into malignancy. So you are getting ample time to prevent this incidence of cancer. Why? By just screening these patients. Whenever you have a polyp, remove the polyp, send it for histopathology. That's all. Because you are having ample time, about 10 to 15 years. By this time, it can change into malignancy. So this is very important, very vital, that when you get a polyp, remove the polyp and put the patient on a strong screening program so that you can check it whenever it happened. And those patients who are having inflammatory bowel disease, like ulcerative colitis, like Crohn's disease, these patients usually prone to develop malignancy after 8 to 10 years. If a patient is having a disease of ulcerative colitis or Crohn's disease, please keep this patient under your vigilance, that these patients might develop malignancy after 10 years of having this disease. So in those patients, we usually start the surveillance 8 years after the onset of the disease, and we always try to repeat this surveillance every 1 to 3 years. And about familial hereditary syndromes, you see that those who are having Lynch syndrome, why it is important to detect the Lynch syndrome? This is because we can easily detect this by our immunohistochemical test. The Lynch syndrome peoples, the whole colon is very fertile to develop malignancy. So when you detect a Lynch syndrome, say suppose that the patient is having a growth in the right colon, but if we detect the Lynch syndrome, then we don't only remove the right colon, rather it is better to remove the whole colon and make an anastomosis ideal with the rectum. So if you go this immunohistochemical test beforehand, then you can decide yourself that what type of surgery the patient needs to intervene. So this is very important, very vital that all colonic cancer malignancy should put this immunohistochemical test, so that can help you that what type of surgery you need, and also it helps oncologists what type of therapy the patient needs. So these are the very important investigations that we should use in every patient. And about FAP, in Lynch syndrome, you see that we used to start surveillance earlier, around 20-25 years, and we repeat it every 1 to 2 years. And in FAP, you see that FAP is familial adenomatous polyposis. It is an autosomal dominant inheritance it has. So we must start it by the years of 10 age. We start coronar surveillance at the age of 10. And one important thing is, if you have a FAP means you are having polyps more than hundreds. And a definite that these patients will develop malignancy. Definitely. So what we do, if we detect a familial polyposis coli in a patient of 10, 12, 13 years, we wait up to the adult age, so that all his or her body should develop, and then we could go for a total proctocolectomy. We remove whole colon and whole rectum and just keep the anus, and then we make an ideal pouch and make the pouch an anastomosis. So all this is screening. So what are the warning signs that we should not ignore? When we should alert that I am going to having this malignant disease? Number one, any patient who considers that he is having some alteration of the bowel habit. What is that? Alteration of the bowel habit means the patient is having a normal stool, all of a sudden he develops diarrhea, or he is having increased frequency, or he is having morning diarrhea. These are the alteration of the bowel habit. You should be very careful. If you have any kind of these symptoms, be alert. If you find that your stool contains blood or blood stained stool, be alert. You may have some abdominal discomfort, pain, be alert. And two important things: unexplained weakness. Any patient come to you with unexplained weakness, put the patient on colonoscopy. Many doctors misunderstand this and they go for hematological examination, so and so and so. Any patient, elderly patient, explain to you that I am having weakness, but I don't know what for this weakness. Please put this patient on colonoscopy. And these are the patients, they also call for weight loss. So unexplained weakness and the weight loss, abdominal pain, stool in the blood, and also sometimes they can say that they are having some feeling of incomplete emptying of the bowel, some difficulty in bowel motion. I feel very weak. So be alert whenever any of your patient having these symptoms, put the patient on colonoscopy. How can we lower this risk of having this malignancy? So far so long we have learned the screening. So far so long we have learned the symptoms, and now let us put few important things that how we can reduce this risk. A balanced diet is very important, rich in fruits and vegetables. Fiber containing vegetables are very important. Consume as much as possible the fruits and vegetables and whole grain. And doctors always remain busy with their patients and their study. No, you need to have a very active physical life. So you have to make some time for your physical activity every day. Do some physical work, do some physical exercise, and thereby keep yourself active. This is very important. Active life. And of course, you need to restrict yourself from certain food, like you try to consume less fat. Do not indulge yourself taking more red meat and processed meat. Red meat, processed meat are always bad for your health, and they are prone to develop colonic malignancies. And what is more important? The most important is, yes, you must start screening at the age of 40. These are the important things by which we can lower the risk. What are the other things? As I said, that alcohol and smoking are the two important things. So, reduction in smoking and alcohol. Reduction in smoking, alcohol. Please, those who smokes, try to stop it from today onwards. Alcohol, yes, some of our friends consume alcohol, but they are, I think, social consumers. They do not consume. But I feel that we must also stop all those things. Diet modifications, as I mentioned, fiber containing vegetables, leafy food. You need to take a good amount of water, avoid red processed meat. And you see, according to some books, it is around 12 to 16 ounces of meat you can consume per week. And try to avoid pollution, environmental pollution. Don't put yourself where you think that the environmental pollution is more. Try to avoid it. And another important thing that we use always, different long time antibiotics. Antibiotics change the environment of our colonic environment. This antibiotic means there are lot of bacteria, fungus, virus inside our colon, and they maintain a very cordial ecological environment in our colon. If we use external antibiotics, they changes this environment, and that changed environment are more prone to develop colonic cancers. So what is the take-home message? You see, all sitting here are close to 45, if not 45. You know what is my age? Can you show?
45.
Yes. If you are 245, then I am close to 245.
So you didn't go for the colonoscopy yet.
Oh, I did. So I am now running 70. Yes. If 69.
Where are you?
Oh,
Why
she's
are
my,
you
both are my close friend, sitting together, and my classmate.
No,
They
you
said
are not
that
70 yet.
close to 68. 68.
65.
Oh no! I am retired from medical university at the age of 65, about 3 years back. So I am at least 68. 68. So take a message that please, it is a time to screen yourself for colorectal cancer and go to the gastrointestinal and hepatobiliary department and get your colonoscope done by your. Please stand up and let them see that our gastroenterologist is here. So we take help from him. And these are the references from where I got this information, and I think I take a lot of time, so I wish you all thank you very much. Have a good information, and I think everybody will have a colonoscope, and be safe for your future, and try to avoid having a colorectal malignancy. Thank you very much. Thank you.
So thank you, sir, for your nice and deliberate presentation. And now I would like to invite Professor Dr. Farah Hussain, ma'am, consultant, Department of Gynecological Oncology, BSH. Her topic is awareness and screening for cervical cancer. Please, ma'am, come on the dais to deliver your important.
Assalamualaikum, Chairman sir. Before you leave, I want to ask you a question. Just enter. If Professor Zaidullah has taken 30 minutes of presentation, how long should I take to communicate the message to the audience who are not in of my subject? Tell me that and then leave.
I'm coming, not leaving.
Yes, give her the
I'll be coming in presence of
So how are you going to complete the 5 speakers?
already one speaker dropped.
One speaker dropped.
So now, four speakers.
Okay. Assalamualaikum. We are observing World Cancer Day. Though we are late, the Cancer Day was on most probably 4th of February this year. So in spite of doing on that day, instead of doing on that day, we are doing it now. The topic is, respected chairperson, he has just left, the chief guest, special guests, panel of experts and dear audience. The topic is cervical cancer awareness and screening. So we know that cervical cancer is a public health problem, and according to Globocon 2022, the incidence is 6,62,000 and the death from the disease is 3,49,000. Bangladesh perspective, if you see, the prevalence is 2,70,000 and the death from the disease is 6 lakhs. So we have a statistics which shows that in the world it is the fourth most common female cancer, and in Bangladesh it is the second most common female cancer next to breast cancer. So why we are so eager to create awareness about the disease? As I've already mentioned that this is a public health problem, and the cancer globally and in Bangladesh, the fourth and the second cancer. Another important thing that it is a silent disease. Early stage cervical cancer really causes symptoms. So if we do go for regular screening, we are only able to detect the disease. It has a success story, empowering women through education, providing access to preventive measures like HPV vaccination and regular screening reduces the global burden of cervical cancer. So it is very important to create awareness regarding cervical cancer, and about 50% of the audience are male, so this message will be conveyed to your wives, to your sisters, so they can be aware about the disease and have themselves screened. The global strategy for cervical cancer, it was set in 2022 by WHO. They set a target to be achieved by 2030, where the targets are 90-70-90 targets. What do we mean by 90-70-90 target? The target was set to eliminate cervical cancer globally. Now, Bangladesh is committed to achieve this target, and we are, along with the government, the Society of Bangladesh, are working hard to achieve the global. So what is 90-70-90? These are the 3 pillars where we are working. 90 means to vaccinate all the girls below the age of 50 years, 90%. So by 2020 our target is to achieve the HPV vaccination for girls below 15 years. The next is the 70% target, means that 70% of the women must be screened by a high performance test within 35 years of their age, and next screening should be done at 45 years of age. The last target is that once you have done the screening and the HPV vaccination, you are left behind with the treatment, and this treatment includes the treatment of both pre-invasive and invasive cervical cancer, and 90% of those patients who are already diagnosed as pre-invasive or invasive cancer must be treated. Now, today's talk, I will be totally concentrating on the screening. Neither the HPV vaccination nor the treatment part will be touched. So I will be confined totally with the screening. Now, if you want to do the screening, we need to know why cervical cancer happens. So human papilloma virus is a virus which causes the disease, and it has been established after decades of researches that this is the causative agent for cervical cancer. But any type of human papilloma virus is not going to make the disease. So we need two important things. The important part is that the infection that will happen with human papilloma virus must be a persistent infection, and the virus must be a high risk virus. Now, what do we mean by persistent infection? Persistent infection means having an infection with the same strain of HPV, high risk HPV, for more than 2 years. So if a woman is found to be is detected with a HPV virus persisting for more than 2 years, we say that she carries the risk of having the malignancy. Now, we know that human papilloma virus is a sexually transmitted disease, not limited to intercourse only. I'm not going into the details of what are the other ways of having the human papilloma virus, but purely it is a sexually infected disease. Now, many women in their lifetime will acquire the HPV infection at some point of their lives, and often more than once. So don't get afraid if a woman is found to have an HPV infection. Just concentrate that there are two types of HPV viruses. One is the low strain, another is the high risk strain. We will be concentrating for the malignancy for the high risk strain. Now, what do we know about the high risk strain? There are 200 types of HPV viruses, but we will be concentrating on the high risk type. HPV 16 and 18 is a contributor of 70% of the cervical cancer, and it plays a predominant role in the development of cervical cancer. Next comes the HPV 31, 33 and 45. They also plays a significant role in the development of cervical cancer. And last of all, HPV 52, 56 and 58. These cancers, as so far as the researchers tells us, that these are mostly found in the China region, and they also contribute in the development of cervical cancer. Together, these 8 strains, they are called the oncogenic strains. They account for vast majority of the HPV related cervical cancer. The persistent HPV infection is the causative agent, but it would not happen alone. If this persistent HPV infection is combined or associated with the risk factors, they carry the most important risk of developing cancer, because the mutagenic process or the process of carcinogenesis then starts. And this is known by everybody that early marriage, sexual activity at an early age of life, multiple sexual partner, poor genital hygiene, smoking, multiple pregnancies, weak immune system and oral contraceptive pills, all these play a major role in the development of cervical cancer along with persistent HPV infection. Don't be afraid of giving your wife's oral pill. You can take the oral pill for many years as you like, but we are concerned not to take the pill after 5 years, because after 5 years, if a woman is repeatedly taking the oral pill, the cervical epithelium becomes unstable and the mutagenic process starts there. Now, before I go to the screening, what do you mean by screening? Screening is the presumptive identification of unrecognized disease by means of test examination in order to permit timely intervention. In cervical cancer, precancerous cervical lesion and early invasive cancers are identified by screening. Now, there are many female cancers like ovarian cancers, endometrial cancers, but we are more interested about cervical cancer because this is the very important female cancer which can be screened. And the points in favor of screening are, these points are not available in other cancers. That's why we are unable to screen ovarian cancer. The important part is the accessibility. We can put our cusco-speculum and see the cervix whether it is healthy or not. So this is a very important favorable point where the patient can be screened. The second point is the propensity of the cells to exfoliate. We do the test, but if the cancer cells are not available, how we are going to pick up the cells? In ovarian cancer, we are unable to pick up the cells. That's why we cannot go for screening in ovarian cancer. But here, the cells drops down from the surface of the cervix and we collect those cells and we subject them to tests. Prolonged natural history, it takes about 10 to 17 years times to develop cervical cancer. So it is a long natural history of the disease. Presence of a valid and acceptable screening test, it is available, the PAP test, the cytology based test, the VIA test and the HPV DNA test. These tests are available and we can screen the patient. Existing of a spectrum of histological changes from mild atypia through pre-malignant lesion to frank malignancy. It goes steps by step. That means you will not develop the cancer de novo. That means just you saw and the malignancy has developed. No, it goes like pre-invasive unhealthy cervix, pre-invasive cancer, then develops the cancer. As I told you before, it takes a longer natural history, long time to develop a cancer. Earlier and efficient diagnosis of the disease, effective therapy against detected disease. Now, as I talked before, there are 3 screening methods by which we can screen the disease. The number 1 is the PAP test or the cytologic based screening, where the physical changes in the cervical cells are identified and the precancerous lesion is detected before it becomes malignancy. You see in the first picture, the patient is put in a lithotomy position with the help of the cusco-speculum and eye spatula. The cells are collected from the cervix and endocervix. The second test is the HPV DNA test, where we are detecting the presence of HPV strains, including the high risk, even when the cells still appear normal. No changes, physical changes has taken place in the cells. Only the findings of the high risk HPV DNA makes you aware that you need to screen the woman. So this is the kit, the first picture, and the second is the HPV virus. VIA, visual inspection with acetic acid. This is an acetic acid or a dilute vinegar which is put on the cervix for 1 minute, and after 1 minute we observe the change in the color. If the cells contain the abnormal tissue or there is atypical cells, what will happen? The color of the cervix will take a change into white. That means it will become acetowhite. The first picture tells you about the normal cervix, which is called VIA negative, and the second you see that it has changed into acetowhite color, which is VIA positive. Now, this VIA is a very easily detectable test, can be performed by the grassroots level worker, and it is a test for the low resource countries like Bangladesh. Amader deshe we are practicing the VIA. Now, when you look at the analysis of the sensitivity and specificity of the screening test, you see that HPV DNA test is a high performance test where the sensitivity is in between 94 to 96% and the specificity is also high between 80 to 90%. So there is less chance of having inaccuracy in the test. On the other hand, if you go to the PEP test, you see it has a low sensitivity of 50 to 70%, though the specificity is high. VIA has similarly a low sensitivity and specificity is high. So we will be preferring to have a high performance test for the screening purpose. The low performance test like PEP test and VIA is not going to solve the problem of Bangladesh having a population of 17 crore. So this must be kept in mind that if you do a screening test, please go for a HPV DNA test. That will give you the result very accurately. As I told, VIA is optimal, low cost and effective cervical cancer screening program in Bangladesh. Women between 30 to 60 years are screened every year since 2005. We have started this national program in 2005. The procedure is conducted by trained nurses at government medical colleges, district hospitals and selected Upazila health complexes. But it has definitely limitations. That's why it is a test which is mostly done in the low resource settings. It is a provider dependent method. That means it is only the eyes which sees the disease. You cannot say with the test that I have found this and so it is the disease. So I will tell you whether you need to collect the biopsy or whether to send the patient to the next step. So it is a provider dependent method. It has a low specificity with a high false positive results. Less effective in postmenopausal women. Jara boysko, this test is not going to give you any benefit. আমি কারণ আর বললাম না. The accuracy of VIA is disturbed in presence of STD and render visual inspection difficult. Similar to VIA, the cytology-based screening PAP test has also limitations. The sensitivity, as I told you before, is low also. Cytology is poorly reproducible subjective test without quality control. It is labor intensive. That means you need a good manpower here. That means you need an expert cytologist. You need a good infrastructure. You need logistics to perform the test. And it's a slow moving test. You cannot make high volume test to do the screening. So in one word, high quality cytology is expensive. Moreover, there is 3-visit approach to intervention. That means if you want to treat the patient, you need to do the cytology, subject the patient to colposcopy and then do the treatment. So the patient has to come thrice to do the test. Now, as I told that HPV DNA test is a high performance test because it has a highest sensitivity among the screening methods. The specificity is also high in detecting precancerous gland. It is amenable to automation which makes attractive for high volume screening. So you can screen many numbers of patients at a time. Cross specimen contamination is low. There's no need of special laboratory facilities. In Bangladesh, now Dhaka city has the facility to do the HPV DNA test. But the facilities are limited in Bangladesh Medical University and ICRH and Dhaka Medical College recently. The private hospitals have also started the disease and big private hospitals are also having HPV DNA test, including Bangladesh Specialized Hospital, and we are doing it for the last 3 years, I think, that HPV DNA test is done. When should you get screened? You need to know when your wife should be screened, when your sister should be screened. The age, as WHO has recommended, is between 25 to 65 years. For Bangladesh, we say 30 to 60 years. And if you do HPV every 5 years, that has to be reported because it is a high performance test. You give a long interval. When it is PEP test, it should be repeated every 3 years. And when it is VIA test, should be repeated every 3 years. What will you do after the age of 65 years? You don't need to do any screening after 65 years if a series of prior tests are normal. That means the previous tests which you have done are all normal, so you don't need to screen. The important part is now, many of you have a misconception that I have already given my child or my wife HPV vaccination. Should I screen her now? When she gets married or not married, screening is important. So yes, you need to, even the patient is vaccinated, you need to screen the patient. This should go side by side, not one done, it must go side by side. Women who have been vaccinated should still be screened for cervical cancer, as the vaccine will not protect her against those types of HPV strains by which she has already been infected before or after receiving the vaccine. I make it more simple. You have given her a bivalent vaccine of HPV 16 and 18. Now she is being infected by HPV 33. How she is going to be protected? So you need to screen the woman even she is vaccinated. I've made it understand she can be infected with 52. She can be infected with 56. So in order to protect herself against the age strains, you need to screen the woman. I'm in the last part. So what can you and I do? Be informed and raise awareness among family and friends. Ensure timed screening and vaccination. Work to dispel myths and misconceptions. There are so many misconceptions and myths which have not talked, but this exists, and that's why we are not successful in the screening program. Last slide. Cervical cancer is preventable, treatable and curable when detected early. By prioritizing regular screenings, vaccinations and healthy lifestyle choices, women can significantly reduce their risk. Thank you all.
Thank you, madam, for your nice and elaborate presentation, so that we females can be improved about our screening. Now, for limitations of time, I would like to inform all of you. Our third speaker politely argued about not to present her case for this session, and in very short future we are going to present this session again. Thank you, ma'am, for your patience, and I also like to inform you that in the CME, our chief guest of this session, Professor Dr. Kanujaman Choudhury sir, for very family emergency condition, he was not present at this session, and after that it's now time for most important part of this session, that is integrating clinical expertise with artificial intelligence. And there is something to tell about this before starting the topics, and for this reason I would like to invite Professor Dr. Muhammad Moniruddin sir, team leader, Department of Mathematics and Physics, Pre-Matrix Lab in SU. Please sir, come on the stage and say something before I inaugurate our two speakers.
Assalamu alaikum and very good afternoon, honorable guests, experts, researchers and team members. I'm really honored to be here today, and I would like to express my sincere gratitude to the organizer for giving me a chance to talk about our project OncoVision. Our team member will present after my talk, I think. Actually, I'm the coordinator of this project, but the main mentor of this project is Dr. Haripur Rahman sir. He is here. In 2023, I came here with Dr. Anis. He is our team member. He is one of the member of our big matrix team. For data means we just request him to give us some data of mammogram for breast cancer diagnosis. Then he asked me why I will give you data. What is our benefit? Actually, as a academician, our main goal is we do research for publication. Then I told him, okay, if we can successfully complete this project, we'll be able to publish this in renowned journal. I will give you the co-authorship. Then he said that actually academic publication or authorship is not our main interest. We are not interested very much on this issue. But if you can do something that can help us, that means the doctors, radiologist, oncologist, or hospital or our patient, then we can give you the data. Then I said that okay, if you help us, then we can do that. Then he provided us data, and not only data, actually he give all the support. That means we manually we annotate the data. It took a lot of times, and he validated this, and his team with radiologists validate our manual annotation. Then we train up the model using the artificial intelligence. We develop the algorithm, and at the end we develop the model, and this model is deployed in the hospital. Right now it is under test. That means we are in the testing stage. Right, this OncoVision, our student will show you right now, can analysis or can segment the breast mammogram image and generate a report automatically, right? And I would like to actually thank the specialist hospital because they supported us, giving the data, and they deployed our model here. And in future, actually, this project is continuing. Our target is in future we will develop a platform that can not only report in the generating the report, but also it will help us to predict earlier cancer earlier, and it will give you the treatment planning and also progresses analysis, right? So if in future we get more support from you, and I can give you assurance that we can develop our product in that stage, right? So I also would like to actually our Honorable Dean, School of Engineering and Physical Science, Professor Shahzad Hussain is here. Our Department Chairman, Professor Mamun Mullah is here. I also thanks North South University Authority, because actually for this project our main funding or support is coming from North South University. Also Education Minister and ICT Division also funding a little, and they are continuously supporting us. That's why I would like to thank them. Actually, we are continuing some other project. That means same thing. That means we try to develop for the chest CT scan, head neck CT scan, and also liver CT scan, and also we try to develop a software for radiotherapy contouring. Now, important question actually you may ask, why we are doing this research, why this research is important, right? So you already know that AI is very popular, right, in the health sector, especially in the health sector. And in future, you will see that a lot of technology will be developed based on AI, right? So now question is, and already you are familiar and you are importing some AI technology from outside, right? So we have to remember and we have to be careful about this because this AI technology actually it's data-driven technology. The technology which is developed based on data, right? It is data-driven solution. In other way, you can say. So now question is, if you import some software from outside, these are based on their data. For example, if you import from China or USA, these tools are developed using their data, right? So you know that in the medical science or in the treatment case, actually the demographic information is most important, right? Their demographic information and our demographic information is not same, right? So if we use their technology, I'm sure that you will not get more accuracy, right? That means it will not more accurate, right? That's why we have to develop the technology of our own. That means it is important to develop these kind of tools or software of individual hospital. That means you have to develop the software using the data of your hospital. Then you will get more accuracy, right? And our research is important because if you compare our research with other research, you will see that we are annotating the image from the pixel level. That means to annotate one image, our student took 6-7 hours, right? That is pixel to pixel they annotated this, right? That's why our developed model gives more accuracy. Our student will show you. So I would like to thank again all of you for your support and thanks for inviting me here. Allah Hafiz. Assalamu alaikum.
Thank you, Professor Dr. Mohammed sir. Now our topics is OncoVision Hub, Bridging Mammography and Clinical Data for Precision Oncology. For this topic, I would like to invite Ishtiaq Ahmed and Kadi Shahir Kanji, lead researcher and lead developer, Big Matrix Lab in
OncoVision Hub. Honored guest, esteemed chairperson, respected expert panel and doctors. Assalamu alaikum. I am Ishtiaq Ahmed, lead researcher at Big Matrix Lab from North South University. I am very excited to share our research, OncoVision Hub, bridging mammography and clinical data for better breast cancer research. In Bangladesh, breast cancer is a major crisis. We see over 13,000 new cases every year. Sadly, about 80% of our patients arrived at hospital in the late stages. Mammography, we all know that mammography access remains a luxury in remote areas. This is where our research, OncoVision, steps in to assist radiologists, bringing expert level reporting system to low resource settings. You may ask, why AI? Why AI? Because it acts as an assistant for our doctors. And you can say a second pair of eyes. In low resource settings where specialist care is harder to reach, AI is a game changer. And it also it is also a great tool for education and training. Our medical students and junior doctors can use it to train and improve their diagnostic skill by seeing real-time AI feedbacks. our aim is to build multimodal model. This model can predict clinical features from mammogram and also detect the abnormalities like masses and calcifications. By doing this, the system can automatically generate structured report to assist our doctors. First, we'll prepare the data, we'll annotate and pre-process, then we'll validate this data from expert radiologist. Then we'll develop the model and go to the training process. Again, we will validate the data from the expert radiologist. We will test the predictions from expert radiologist. Then we go for the model model deployment and make a very user-friendly web UI for the doctors. For this research, we have collected over 500 mammogram cases from Bangladesh Specialist Hospital, and our team spends 8 months leveling and preparing this data. We have also validated every case from the expert radiologist after annotating the data. As you can see on the screen, we didn't just label the cancer, we annotated exactly where the mass is, where the calcification is, where the axilla finding and tissues are. And trust me, this is the foundation of our model's accuracy. We also added 10 clinical features into the system, such as mass morphology, mass shape, mass presence, mass density, mass calcification. We have also added the calcification characteristics such as calcification presence, calcification distribution, also ACR breast density and Byrat's category. Our model looks at the mass density, calcification, just like a radiologist does. It also classifies the Byrat's category from 1 to 6. Here are some distribution of features after augmentation. As we all know, medical data are always imbalanced, and we try to balance this distribution by augmentation, by performing the augmentation. Moving on to the model development. For the technical side, we have developed a multimodal model using the mammogram image and clinical image. We have developed a decoder and encoder based segmentation model to segment the mass, calcification, axilla finding and tissues. From this, we have also developed two lead fusion models, independent and dependent variants, to predict the technical clinical features and from the mammograms. I'm not going to the detail of these models. Here is the whole workflow of the OncoVision. First, we have collected the data. Not only mammogram data, we had to collect the clinical data corresponding to the mammograms, and from there we had to annotate all the necessary features from the mammogram images such as mass, calcification, axilla finding and tissues. Also, we have tabularized the data. I have also tabularized the data from the raw clinical data, raw clinical report, such as mass definition, mass density, ACR breast density, Byrat's category. We have to do it for 8 long months. From here, after data pre-processing, we have validated every cases by the expert radiologist. Then we have sent this data to the modeling for the training purpose. After training, we have also validated our prediction from the expert radiologist. Eventually, we have deployed the model in the hospital system. Here is an example. A mammogram is inputted in our multimodal fusion model, and OncoVision segments the abnormalities, analyze the technical features, and automatically generates a structural report. Let's see how our model performs. Our results are very promising, as you can see in this error analysis map, how the model segments mask correctly. OncoVision also shows great accuracy in predicting the clinical features such as mass presence, mass calcification, mass shape. It is almost 90%, over 90% accuracy. We have got also over 92% intersection over union in the segmentation features such as mass calcification, axilla finding, and breast tissue. We have also analyzed the radiomic features such as mass texture, intensity, shape, etc. to enhance the accuracy of Byrat's feature. And we are still trying to improve the prediction of our research. The more data we will have, the more the model will be generalized. This is a common rule for AI development in medical sector. This research is currently under review at Nature Communications Medicine, which validates the scientific strength of our work. OncoVision is not just a research, it is a tool to save lives in low resource settings. Now my colleague will show how this system works in the real hospital system. Thank you for your time.
Assalamu alaikum everyone. So I was responsible for building the software. So as you can see on the left side, you can input the images of LCC and RCC view. On the right side, you get a structured report system. There are some segments. Each segment has sub-segments like mass as definition, density, shape, mass calcification. Also, we have another page called data reports page. On this page, you can filter out the disease type by patient age. Suppose you want to see virus category 4 between patients 30 to 40 ages. You can filter out the patients, then download the PDF. So here is a small demonstration to our software. Right now images are being inputted. Now after clicking the analyzing button, the model will predict the report. Here is the structured report, right side. If the doctors want, he can actually zoom the report and see the segmentation of our model. After that, if the doctors or technologists want, he can download the report. Yeah. So in this report, there are both tabular and image features. The image segmented features and tabular features are present here. And the history page, we can see all the history, and this is the data reports page where all the reports previously made we can be seen from there. Now we currently also working on the lung CT analysis tool. It will segment the same way, but it's building for the lung cancer system. And also we are right now developing the auto contouring system. The UI has been already been made, and we are actually validating the auto contouring system. The manual contouring takes around 3 to 4 hours for a radiologist or physicist to do, but our model predicts in just 30 to 40 seconds. It's around 95% accurate. We are doing it for head and neck, cervix, lung, but we are also want to extend this in the dose prediction and RT planning prediction. It's our future work. Also we are doing layers categorization, HCC detection is also in the development phase. We also work with this type of data, ECG and angiogram. We are trying to find a correlation between ECG and angiogram. It's under development. And here is our future development. We want to collect all the demographic data of Bangladesh and build model for each disease, so the model can give accurate result. Also, it's become very cheap as we are building this in our country. Lastly, we want to thank North South University for funding our research, and special thanks to Bangladesh Specialized Hospital. They helped us to integrate the model and validate the model. And we also thank the ICT Division and Ministry of Education of Bangladesh for funding us the research. Thank you everyone.
Thank you, Kazi Shahir Sanjit and Ishtiaq Ahmed for your excellent presentation and overview over the topics that is highly important for us. And now it is time. I am escaping question answer session because of our time constraint. And now I would like to yes, sir? And now I would like to go to our panel of expert discussion and.
From the NSUR.
Okay, and for that I would like to invite Professor Dr. Maman Molla sir, Chair, Department of Mathematics and Physics. And sir, please.
Thank you. Here I'm very honored to be here, and Honorable Chairman and all of the doctors and my colleagues and my students here. I'm very happy to see that in the panel of experts. Actually, I'm not an expert on the field of cancer or any other things. I'm a student of mathematics, but I do have some expertise or experience working with the doctor. When I did my PhD in the University of Glasgow, that time actually I did my PhD on a biofluid dynamics. That means the blood flow through arterial stenosis. That means what has happened if there is any blockage due to the lipid profile depositing there. That means we call there is a blockage, we need to do the stenting. And I learned something from the doctors